So I've been asked to talk about supportive care. Since I'm a good guy, I'm going to talk about supportive care. So I'm going to talk about three different things. The first thing is to introduce the notion of 10 steps to better care, which is something that is available on the International Myeloma Foundation website. It's a way to structure the approach to management of myeloma, which I think is a very helpful way to break down the evaluation and management throughout the course of the disease. The second thing I'm going to talk about is the management of bone disease in myeloma as an example of the key aspect of supportive care. And the first part of that is something that's been touched on quite a bit, which is where are we with imaging techniques to evaluate and diagnose bone disease in the first instance, and also to monitor that over time. And then the third thing is to discuss the current status of bisphosphonate therapy for myeloma. So the first thing, this is just to show you the 10 steps to better care, which is on our website, and you can see that it covers everything from making sure that you have a correct diagnosis all the way to identifying clinical trials that are appropriate at the time of relapse. Supportive care is step number 4. On the electronic version of this tool, there are a variety of things which are available. First of all, there's a summary of what each step is, but attached to that, there are electronic publications where the publications that relate to frontline therapy or maintenance therapy or the role of transplant are attached, both in the publication form as well as in abstract form. Also, we have videos of our distinguished colleagues presenting their work at ASH and at, for example, the workshop in Paris and the like, so that it's possible to hear verbatim discussion. And we give listings of references and connections. In the area of supportive care, it's quite important to have connections to other resources that are available for all aspects of supportive care. And this just shows you how it looks electronically. You can click on different things, bisphosphonate therapy, anemia, fatigue, all different aspects of supportive care. So supportive care is everything besides the anti-myeloma therapy, although as we all know, the best way to have good quality of life is actually to get your myeloma in remission. So that the best type of supportive care is good anti-myeloma therapy. And so there are these kinds of steps that are related to each evaluation process. So the first thing is for bone disease, as an example, which is what I'm going to talk about. The idea is to identify, first of all, what aspects of bone disease are present. Is there hypercalcemia? Is there bone disease present on X-ray, on imaging? Then go through the recommended baseline testing, which in the case of evaluation of bone disease now includes such things as careful dental examination, so that before you start bisphosphonate therapy, it is recommended that you have dental exam. All the way through to discussions of, if you're going to start bisphosphonate therapy, which bisphosphonate would you use, and how long would you continue the bisphosphonate therapy. And so it discusses what's necessary to diagnose bone disease, and this just shows you the imaging using X-ray. But what I'd like to focus on a little bit is, where are we with the algorithm for diagnosing myeloma bone disease at the present time? And so the main things I'd like to talk about are, if you have a suspected plasma cell tumor or myeloma diffuse disease, we still have X-ray radiologic assessment at the top of this chain. And so I think that in part that's because of the availability of imaging around the world. However, slowly but surely, other techniques are getting integrated into this algorithm. And so the first one here you can see is that if there are not lytic lesions on X-ray and or if there are not fractures related to diffuse osteoporosis or osteopenia, then you have other imaging possibilities. In this case here, I've listed whole body MRI. You could also put in that box whole body PET CT scanning. If there are lytic lesions, then there are evaluation techniques to see what is the risk of fracture and some things like that. And so there are ways right now to start to integrate technologies beyond X-ray, MRI, whole body MRI, PET CT. And what I want to do is to show you some data presented at ASH that move this forward a little bit. So if one tries to compare what are the results of MRI, PET CT, and conventional radiology, there are percentages of positive and negative findings. But actually, the main thing that is an important observation in my mind is that if you look at the footnote to this, the top two footnotes, if you look at PET CT, there are about 30% of patients with diffuse disease that are not picked up with PET CT but are picked up with MRI. So the PET CT is ideal for picking up isolated focal lesions. Conversely, with the current technology for MRI, about 30% of patients you miss focal lesions, and the main reason for that is that you're not doing whole body MRI. In most instances, you're usually doing MRI of the spine and pelvic areas. And so we need to resolve what are the recommended imaging techniques, particularly within our protocols. I think we tend to skip over this in terms of what is the diagnosis and how have you confirmed the diagnosis of myeloma. To a large extent, this is influenced by imaging. 30% difference in the picking up of lesions or the documentation of bone disease with these different technologies. So this is a huge variable entering into trials. And in the MRC study that I'm going to touch on later, a significant percent of the patients actually did not have bone disease in a study that they were evaluating bone therapy. So the big thing to keep in mind is that, for example, in the spine, MRI and PET scanning normally give pretty much equivalent results as far as focal disease. If you have focal lesions present on an MRI scan, normally you will also pick them up on a PET scan. The big thing is that since it's a whole body technique, in a PET scan you will pick up lesions over here in the shoulder, in the rib cage, in distal sites, and you will also pick up soft tissue disease. In this case here, the patient had a plasmacytoma adjacent to the right kidney. So you're picking up the presence of extramedullary disease, diffuse disease, and extramedullary disease is both a poorer risk factor and more common than has been widely appreciated. So what was presented at ASH? I think there was a very important presentation from the Italian group from Bologna, presented by Dr. Zamagni. This is subsequently published in Blood. Actually, it's published in Blood right around the same time, as a matter of fact. What she showed was that if you look at PET scanning in the Bologna protocol, and this is the group that has been looking at TD versus BTD with transplant. If you look at the suppression of SUV 100 days post-transplant, the suppression of PET scanning, so a negative PET scan post-transplant, is an excellent predictor of outcome, including progression-free and overall survival. And so I think that this is a tool that we need to look at as part of the definition of CR and also as a prognostic factor. The German group with Dr. Hillengass also presented a similar type information related to MRI. Imaging is much more broadly used in Germany, both whole-body MRI, where they have quite sophisticated technology, as well as PET scanning. And though they showed that the number of focal lesions present on an MRI post-transplant correlated significantly with outcome. And so we're starting to get some data in terms of how to better utilize this sort of imaging information. Important things to keep in mind are illustrated with the next couple of slides. In the center panels, the 3 panels, you will see that between January and June, the PET scan lesions basically disappeared, and this is corresponding to a disappearance of the M component. In this case, it happens to be in the urine. But at the same time, obviously on X-ray, the lesion in the shoulder is still there, but also the MRI lesion has not gone away during this time frame. And so it is incredibly important to realize that in patients who are responding, it takes a long time for the MRI to get better. And I think that we're all in the debt of Bart Barlogie and his colleagues in Little Rock, where they have done serial imaging on so many patients and published follow-up data, 2 or 3 different papers. But this is just the documentation of the lag time in CR on a PET scan versus MRI. It takes much longer for the MRI to improve in a responding patient who's achieved CR versus the much more rapid improvement in the PET scan results. And that this delay is a matter of months. It can be 9 months, 12 months, even as long as a year and a half before the MRI gets better. So that in evaluating a patient in this 6 to 12 month time frame, you need to be cautious about how you might interpret a stable MRI. The most important thing would be an MRI that might show new disease, which obviously would be important. In terms of the management of bone disease, it's important to realize that although radiotherapy is useful for large painful lesions, or if there's a destructive lesion or a neuropathy, that it does destroy normal marrow. It also does destroy bone cells, and so it's not necessarily going to improve the structural integrity of that region that you radiate in the longer term. And so it's better to rely on systemic therapy than local radiation therapy. Vertebroplasty and kyphoplasty can certainly stabilize fractured vertebrae, and I think that it's pretty clear that these provide important symptomatic benefit. This is just an example of vertebroplasty, and you can see one of the aspects of this is where that the injected cement for augmentation does move around, and there is an increased risk that there would be leakage of the cement, both locally and systemically, with vertebroplasty versus kyphoplasty. Obviously, the advantage of kyphoplasty is that you use the balloon to create a compressed space into which you inject the cement, and so that this accomplishes 2 things. One, it makes it less likely that there will be leakage of the cement, but also it increases the height of the collapsed vertebra, and this can be an important benefit for the patient, who can achieve both very rapid pain relief and also some improvement in structural integrity of the spine and flexion problems. So, what about the use of bisphosphonates these days in the setting of novel therapies? I think the first point to be made is that 10, 15 years ago, bisphosphonates were really a crucial part of our armamentarium, and that treating patients with bisphosphonates dramatically reduced the complications of bone disease. And nowadays, patients coming into the myeloma clinic are very different physically than they used to be in the past. It used to be that patients would come in wheelchairs with crutches and walking sticks because they had such destructive bone disease. Nowadays, we're diagnosing myeloma earlier, such that there's less initial bone disease, but also with the novel combination therapies, there is dramatic early response. 70% of patients will have responded significantly within the first couple of months or so, and so that you rapidly shut down new bone destruction, and so that there is much less reliance on bisphosphonate therapy as a tool to manage bone disease. And I think that we have not quite reached the point of understanding the relative value or need for the bisphosphonates in the setting of this much better novel combination therapy approach. But nonetheless, I think that if you have bone disease, the recommendation is that you would use systemic bisphosphonate therapy. And the starting of bisphosphonates therapy is still limited to patients who do have bone disease, in line with what I was talking about a little bit earlier. In addition to lesions on X-ray, we need to consider other criteria, and so these are kind of up for discussion right now. Which other aspects of bone disease would qualify as actually having bone disease? And I've given you a couple of examples there. 7 lesions, high SUV with bone destruction on CT. I think that there's less reliance on bone density and NTX as definitive markers of myeloma-related bone disease. So there are several guidelines published related to bisphosphonate use, which patients to start with the bisphosphonates, how long, the choice, how do you modify it related to renal or dental issues. Several guidelines are available. They're all actually pretty similar. The big change here recently is that we no longer recommend indefinite use of bisphosphonates. We would recommend limiting the use, primarily related to the realization that osteonecrosis of the jaw is a risk, particularly with Zometa and particularly with use beyond 2 years. If you have a very rapid, excellent response, a patient who has a VGPR and almost certainly does not have new ongoing bone destruction, one can selectively consider stopping bisphosphonates earlier perhaps. The main part to that is that you would restart if there is new disease. The efficacy, the big picture is that the bone efficacy is actually equivalent for both Iridia and Zometa, pamidinate versus zoledronic acid. There definitely are higher toxicities with Zometa, but these toxicities are preventable with awareness, with dental exams, and more careful use of the bisphosphonates, which 10 years ago, we tended to use pretty much with impunity. Obviously, the difference is the Iridia is given over 2 to 4 hours versus the faster administration of the Zometa. This is just to show you the osteonecrosis of the jaws. It is a problem of the jaws. There tends to be some confusion in terms of, well, what exactly is the area that is affected, but I think it's helpful just to see this picture where the osteonecrosis is, in this case here, it's situated in the jaw right underneath the teeth, and so that actually patients can get osteonecrosis of the jaw even in the absence of teeth, so that I have some patients who've actually had all their teeth removed in a particular area, but you can still get osteonecrosis of the jaw in this location, and so it's clearly something that's occurring independent of inflammation or infection or other issues that may be stemming from the teeth. It is something that's happening with the repair processes involving the jaw. So what do we recommend to avoid this? For any of you who've experienced this with your patients, if a patient gets serious osteonecrosis of the jaw. This is a big problem for the patient. It's painful, it can get infected, some patients can even lose half of their jaw. So even although we're talking about a small percentage of patients, 2%, 5%, 6 or 7%, it's incredibly important to avoid it. So you definitely need to have a dental evaluation pre-therapy, and you need to have checkups along the way and avoid interventions. There are things that you can do as treatment, antibiotics, minor dental procedures, and I think that the consensus is that you should stop bisphosphonates in patients who get ONJ. There are some people who don't do that, but I think that the consensus is that one should. A very important study was published by the Greek group Demopoulos in the American Journal of Oncology, where they showed that with these procedures, with dental evaluation and more aggressive intervention in a careful way, you can significantly reduce the likelihood of getting ONJ. So a very important reduction in this study was shown. Perhaps the most controversial piece of information about bisphosphonate comes from the MRC studies, 2 or 3 papers actually published by Gareth Morgan. It's a large study with 1,970 patients where the Zometa results were compared with clordronate. And the big point that caught people's attention was that there was a 5.5-month survival improvement with the Zometa over the clordronate, an oral bisphosphonate used in the UK. And in all the different parameters, in terms of overall survival and PFS, there was a benefit in favor of the Zometa. I think that I have some cautions about this particular study, in part because not all the patients actually had bone disease. And the other is that the survival benefit actually accrued within the first 4 months, and after that the survival lines are actually parallel. And so that the impact on survival was actually related to what happened within the first few months of myeloma disease control. And it did not convince me that longer-term use of Zometa was something that could be recommended coming out of this particular study. So I think that this could be an area for discussion if people might feel differently. There are lots of new things on the horizon and actually currently available for bone disease. Denosumab is available for treatment of bone disease, although it's not specifically approved for myeloma. And there are several other ideas in terms of how to control bone disease. Both Velcade and Revlimid do actually improve bone disease. Revlimid inhibits osteoclast function, and Velcade actually improves osteoblast function. So the overall strategies for bone disease, I think it's crucial to correctly diagnose and monitor bone disease. I think we need to be much more careful with the bisphosphonates, and I think that to achieve control of bone disease is very important with orthopedic surgery if necessary, with kyphoplasty, and to recover full functional activity with exercise and to reduce pain, but also to avoid risky situations. And so this is certainly not something to be recommended for myeloma patients. You might fall over and break something. So I think that we do recommend exercise. I guess my slide of where that exercise might be is not on this talk, but just having a walk in the woods is better, where you are exercising but not getting too much sun. The last thing that a myeloma patient wants to get is melanoma. So, okay, thank you for your attention. Bye.